Hello, everybody. It's me again, Peter. Today we're going to talk about psychiatric emergencies, which is chapter 22. So a little bit about psychiatric emergencies. These may be chronic issues, but when we deal with medical issues or psychiatric issues in the pre-hospital cares, it tends to be an acute flare-up, so to speak, of their ongoing mental health issues. Very often it can also be related to a temporary mental health issue due to a substance or even a medical problem or stress. It's not uncommon for everyone to have some sort of emotional crisis. It's how that person is able to deal with that crisis or the severity of that emotional crisis that makes it an emergency. Here we're talking about the most common misconception is that if you're feeling bad or depressed, you must be sick. Depression is an illness, but being sad over the loss of a loved one, being sad over the loss of a family pet, those are normal feelings. It's when that sadness or that depression starts to interfere with your daily ability to function properly, and you get a diagnosis of depression. Do you have some sort of mental illness at that time? I don't like how that statement is worded, where it's a misconception that if you're feeling bad or depressed, you must be sick. Being sick means you have an illness of some type. Depression is an illness. It's not the person's fault they have depression. So that wording on that's not really something that I like. Mental health issues are illnesses. Schizophrenia, depression, bipolar disorders, they are mental health illnesses. All right. But just being sad, again, does not make you mentally ill. There's many things that can cause someone to become depressed. And again, it's really going to address the longevity and the impact of that depression on whether or not someone is being is going to be diagnosed with some sort of mental illness, such as depression. Obviously, divorce, loss of jobs, death of a friend or relative. These are all things that having some depression after one of those events is very common. Some people may need some temporary help to get through some sort of short time period. They might need some counseling. They might need to be on some medication. But when that depression becomes chronic, is when I would move it on to the mental illness or mental health category. Not all mentally ill people are dangerous. There are many people who are schizophrenic who function normally every day. They take their medication, they're stable on their medication, and they have no sort of dangerous outburst. There are others that make the news and you see on the streets that sort of freak you out. So because you see them and they're so noticeable, you start to think that, wow, all of these people who have these mental health illnesses must be dangerous and unstable. But the large majority of them function every day through their medical treatments, through their counseling treatments and everything else. But we sort of see a disproportion of the ones that aren't functioning well in EMS. So we sort of get a very skewed view of how many mentally ill people are not stable or who are dangerous because of the segment of the population we deal with. And that again continues here with that previous slide. Not all individuals with mental health disorders are dangerous, violent, or unmanageable. Most, even if they're having a crisis, can be managed with de-escalation techniques, verbal commands, establishing trust. And you may be able to predict violence when you do have a patient based on their body language, their speech pattern. But again, I would say in the 25 plus years I have been doing this, in many mentally ill patients, I believe we've only had significant issues in which we had to deal with assaultive behaviors, probably less than 10 times in my experience. So what is a behavior crisis? A behavior is what you can see of a person's response to an environment. So most people respond to an environment stimulus in a reasonable manner. When someone starts to have a behavior crisis, they are unable to cope with these normal behavior or environmental stimulus, and they act out in some way. And these could be stimulus that you as a person might not even realize are there because they're not bothering you. Uh, think of it, we all have some sort of friend who has some level of, would say, OCD. And you might not even notice the magazines on the table not being ordered in the perfect order, but that friend of yours with OCD, they got to come in and organize those magazines. And we sort of laugh at that person because it's not a life-changing issue for them. It's not disruptive. It's not something that's going to freak them out too bad if they can't organize those magazines. But you as a person don't even notice that as a stimulus for that OCD person, those magazines not being stacked properly. So same thing goes with these behavioral crisis emergencies. Small stimulus in the environment can trigger someone to have a behavioral crisis. And so one of the things that when you have these patients is you want to sort of figure out what's causing their emergency. If you have people that might be agitated, violent, or uncooperative, again, always call for help. EMS and the police are called when someone is displaying behavior that's unacceptable to the community, the family, or the patient. 911 is called to save the day, and suddenly we are now addressing somebody who has a significant mental health issue, who is acting out aggressively or violently towards themselves or others, or acting bizarrely in the community by walking down the street yelling at cars or something of that nature. So if an abnormal, disturbing behavior lasts for a month or so, it becomes a matter of concern. I would not even wait a month. If you have a family member, colleague, friend who's displaying odd behaviors, get it addressed sooner than a month. But when you're doing your patient history, it's good to know from the patient may be able to tell you, or family. Psychiatric patients tend not to be the best historians for their current psychiatric emergency. Many are very forthcoming with their long history of what's going on with them. But if they're having an acute psychiatric emergency on the side of the road and they have an altered mental status, they're probably not going to be able to show you or tell you what's triggering them at that moment. When we see these psychiatric emergencies, we'll see agitation, we'll see some violence. They may become a threat to themselves or others. Some of the abbreviations we use is DTS or DTS, danger to self, or DTO, danger to others. We want to know if they're suicidal or homicidal. So you'll see SI, which is suicidal ideations, or HI, homicidal ideations. Assume that any person who is suicidal is also homicidal. If they really want to hurt themselves and you try to interfere, they will hurt you so they can continue their task of hurting themselves. So be very aware that if someone wants to hurt themselves, they're very capable of hurting you. Mental health is an extremely big issue in the United States. More and more people are being diagnosed with mental health issues. They be related to a variety of issues, drug use being a big one. It is considered a psychiatric disorder, again, when it starts to impair daily functioning. So again, sadness over the death of a loved one, you're still functioning, maybe you take some days off of work, but you learn to cope with the loss of the loved one and you get back to work. You're still in a little bit of fog, but you're back to functioning, and in a couple of weeks you've sort of moved on to your normal mental health state. You have that person that gets into that funk, right, that depressive funk, and they just can't get out of it. They're sleeping in late, they start missing work, they're calling out of work, and this is going on for a couple of weeks, couple of months. that's definitely a time to start seeking help. Some of the categories, we have what we call our anxiety disorders. We see our generalized anxiety disorder, panic attacks, phobias, PTSD, obsessive compulsive disorders. Most of these disorders, or all psychiatric disorders, are described in a mental health manual called the DSM-5. Actually, sorry, it might be the DSM. Yeah, it is the DSM-5 at this time, which basically identifies all psychiatric disorders by signs and symptoms and lengths of time in which they have to have these signs and symptoms before they can be given that label. Many of our psychiatric patients are treated through outpatient. We don't do long-term inpatient like we used to 30, 40 years ago. There's many issues of institutionalization. There you go, that's a good word, of the mentally ill back in the day, but now with new treatments, new antipsychotics, new medicines for depression, many of these patients that would have been placed in institutions up until the 1970s can function either in outpatient settings like adult group homes or in their own homes with psychiatric care through visits to a doctor or counselor, through visits to their own home by clinicians. We do have several psychiatric facilities here in Tucson, and usually there are several days to maybe up to 30-day long visits. And we do have a state hospital in Phoenix, the Arizona State Hospital, and that's going to be for your more long-term, severely mentally ill, dangerous patients would be in the Arizona State Hospital. Psychiatric disorders can have some underlying causes. Again, we have social and situational stress. This would be your divorce and your loved ones. Diseases such as schizophrenia and bipolar disorder. Understand that physical diseases or such as diabetic emergencies can cause someone to become agitated and have an altered mental status. But if you are able to reverse that or the medical issue, the mental health issue will go away. Drug-induced psychosis, damage to the brain by the use of drugs can also cause psychiatric problems that become permanent. And electrolyte imbalances and even environmental issues like severe heat can cause someone to have a psychotic episode. So as EMTs, we are not here to diagnose their mental health conditions. We basically are going to treat the signs and symptoms and get that patient to the facility, the emergency room in which they need to be stabilized and treated, and then either released home or released to a mental health facility of some sort. So a couple of different types of the pathophysiology of mental health issues. We have our organic issues, your organic disorders. That's some sort of permanent dysfunction of the brain caused through some sort of physical or physiologic issue with the brain tissue. So these could be the behavioral issues related to having a TBI, a stroke, a seizure, drug withdrawal. And you have your functional disorders, which are going to be those disorders that impair the body's functions. So I'll read that. A physiological disorder that impairs bodily functions when the body seems to be structurally normal. So we understand that person who had severe brain injury, who no longer has a proper thinking process. But for the schizophrenic, there was no trauma. There was no introduction of a drug to cause them to hallucinate. They have some sort of physiological function disorder that causes the schizophrenia, the anxiety, the bipolar disorder, and the depression. All right, so how do you approach a behavioral crisis safely? Again, with all our patients, BSI seen safety even though this is not a trauma patient, you still need to have your gloves on. You always have to deal with maybe this person wants to decide to become aggressive. Maybe they want to spit at you. They might not be very clean based on their mental health issues. They might have poor social or physical hygiene. So all those bodily fluids are there even with the mentally ill patients. So the big thing dealing with our mentally ill patients are those de-escalation skills and those communication skills. All right, so when we do our scene size up again, always talking about safety, take appropriate safety standards, request police. Usually with our mentally ill patients, law enforcement will be there first to make sure it is safe for us to be there. If a patient is suicidal or homicidal, the police need to be there before we're there. This patient is acting aggressively or being violent towards themselves or others, the police need to be there first. We put a lot of pressure on our police departments because we expect them to be able to handle these medical patients. And there's really sometimes no safe way to handle some of these medical psychiatric patients without restraining or law enforcement needing to use non-lethal methods such as tasers. And again, those are what makes the news. All our mental health patients, though, 99% of them are nonviolent towards us and are just having some sort of mental health crisis, just not involving harming themselves or others. But when you see it on the news, it seems like all of these mentally ill patients are out there fighting and acting crazy. And that's not the case. But again, we never know when that's going to happen. So we always have our police officers there to help us for these mentally ill patients. So looking for those medications that might be in the house, something that you're looking for at the scene. Are you going to a group home? Are you going to a mental health hospital? Is this an adult care home? Those are things that you might want to know when you're heading out to this scene. We have our computer-aided dispatch. If this is a house that is a frequent flyer house, it might be in the notes that will be provided to you during your dispatch that, hey, this is a person with a history of schizophrenia or a person with a history of depression or anxiety. And so it can give us some additional information on our response. Our primary assessment, as always, your general impression. As soon as you get to the house, is the house well kept? Not always a sign of anything, but sometimes a disordered house is a sign of a disordered brain. Do your rapid, quick visual head to toe of the environment. How is this person speaking to you? Establish that rapport, introduce yourself, non-threatening manner. They're sitting down, approach them, maybe bend down at their level so you're not towering over them. Your choice on whether or not you want to sit on their furniture or just sort of crouch down. Just make sure you crouch down with a little space between you and the patient. So if you have to back away quickly, you have that time and space to allow you to back away quickly. All right. A lot of our mentally ill, they're going to be conscious, awake, and oriented, or at least conscious and awake. They have open airways. They're talking to you. Whether or not they're talking to you in a rational manner, that's a different story. But usually assessing airway and breathing and circulation is pretty basic. These patients are alert, at least per the AVPU scale. It's just their thought processes are disordered, which is why they're having this crisis. If they're having a trauma issue, then you definitely need to take care of those trauma issues. And unfortunately, if they are having a severe mental health issue with their schizophrenia, they're hallucinating or anything like that, trying to treat some traumatic injuries might be difficult. But again, establish that communication at the beginning. Even our patients with mentally ill, unless they have some significant schizophrenia, they're usually going to be cooperative with you to an extent. Investigate the chief complaint. Ask, hey, how can we help you today? What's bothering you today? Uh, are there any central nervous system issues? Are they delusional in their speech or their thought patterns? Do they appear to be hallucinating on anything? Do you see drug paraphernalia? Any significant life changes? Sometimes they need to, if they're having depression, they're going to tell you their whole life story about all the sadness that has occurred to them in the last week, in the last month, in the last 2 decades. Listen, you do sometimes have to sort of politely interrupt so you can move on to your next part of your history taking, but at least you get that idea from the patient of what's going on in their life. And you want to know what caused you to call us today. And sometimes it's, I just can't deal with it anymore. And it's 3 a.m. and they're laying in bed, they can't sleep, and they just can't deal with it anymore. And they need to call somebody, and 911 is who they call. So they just need someone to talk to, and we get that patient to the hospital. Are they going to die from that depression tonight? Probably not. But do they need someone? Are they having a crisis in which they need to talk to someone? And the hospitals can get social workers available. And a lot of these patients, they're resistant. This is not their first time doing this. And it's very frustrating for them because mental health issues in some ways are harder to treat than some physical issues. Uh, it's not something that you can just take a pill and it goes away. These are just these chronic, ongoing issues that are very just difficult for the patient because they know there's something wrong with them, and it's not something that you can just snap out of. And it can cause all sorts of other anxieties because it's not something that they can't snap out of. And people look at them and they're normal and they're just, why are you like this? And the patient can't even explain why are they like this. So just be aware that these patients that have had these lifelong mental health issues, it's very draining on their spirit, so to speak. And that just sort of contributes to the mental health issues that they're having. You do your sample history, use what we call that reflective listening. Again, sometimes you have to sort of help the patient stay on track with what you need answers to. But if they can't, that's part of the signs and symptoms of the mental health issue that they might be having. Here are some basic questions to ask for someone who might be having a mental health crisis. Big things: are they answering questions appropriately? Are they rambling? Are the behaviors appropriate? Are they responding to stimulus that are not there? Is their memory intact? Basic questions. You don't need to know all of those, but just get an idea of some basic questions that you want to ask someone who's having those sort of mental health issues. Your secondary assessment, obviously, if they're unconscious, you're going to begin with that physical exam, your ABCs and your head to toe. A conscious patient might not always respond to your questions. If you get someone who's sort of in this catatonic space and they're just there staring at you or staring into space, they're not really responding to any stimulus in the room, you have to be cautious because you start touching this patient, will this patient act out physically? So you definitely want to do a cursory physical exam, but maybe not as detailed as you would if it was a full-blown trauma patient, because the goal is for these patients isn't to antagonize them. You're not going to be able to fix that mental health issue. It's to get them safely to the hospital or to the facility in which they need to be treated appropriately at. So if you have that patient who's obviously agitated and you can get them to the gurney and they'll cooperate, and you can secure them with your straps and rails like all patients, and you let them know that, hey, all of our patients have to be secured with our seat belts. But you can tell that taking a blood pressure or blood sugar will just agitate them. Don't take it, but document. And document what you can see. You can see skin color. You can see respirations. You can see pupils from a distance. These are things that you can, document. Document the body language. Patient was very rigid. Patient had clenched fist. Patient appeared to increase in their agitation when I would speak to them or get a history. And so you document that so you have that to back you up when you get your chart reviewed on why didn't you take a blood pressure and stuff like that. Transport decisions, again, law enforcement can ride in the back with you. We do not transport people in handcuffs unless the police officer is in the back of the ambulance with you. They are not to be in the car behind us. Anyone in handcuffs has to have a police officer in the ambulance with the patient. All right, but have a firefighter or another EMT in the back with you, even if that patient appears stable. If your gut is like, hey, this guy looks like he can just go off at any minute, have someone back there. You do not want to get into a fist fight with a patient in the back of your ambulance. It's not safe, obviously. And when people have some sort of mental health crisis, they, in many cases, can take on some strengths that you would be surprised that they have in them. We want to continue to reassess, keep your space between the patient as best as you can. Watch for things like that patient trying to unbuckle the seatbelts, see how they're moving in the gurney, observe their breathing. If you start seeing them breathe heavier, ask, hey, is everything okay? Anything I can do for you? You doing all right? And sometimes they won't answer you. They look at you with that death stare. All right, you better make sure you're ready. Let your partner know if possible. Have some key words that you might need to yell out to your partner in the event that there's an emergency. Maybe position yourself closer to the head of the gurney so you can move and communicate to your partner, hey, we need to pull over and get some help. This guy's about to lose it. Those types of things. Again, most of the time you can diffuse situations verbally with de-escalation. In the city of Tucson, you're going to be able to get to a hospital, usually 10-minute transports. I sometimes work in rural areas where I have a 45-minute to an hour transport. That patient would have been fine in Tucson. I would have got him to the hospital within 10 minutes. But as we're going down that long highway and that patient has time to think and starts perseverating on thoughts and stuff, you can sometimes see them get more agitated, even if you are trying to diffuse situations. They start regretting calling 911, getting angry at family members who did call 911. They have their cell phone and they're texting people, and that's a whole nother issue on what you want to do with cell phones in your patients. Sometimes it's like, do you want them to keep their cell phone because it keeps them distracted, or are they texting people that are agitating them even more? Or do you take the cell phone and then they want it back? That's really not my experience. If they want their cell phone, let them have their cell phone. We're not going to fight over a cell phone in the back of the ambulance. Unless they're a child and the parents don't want them to have a cell phone, then I give that cell phone to the parents. For us, we can restrain. Again, you need at least 4 people to physically restrain somebody safely, 5 preferably. So you have 1 person on each limb and then 1 person controlling the head. For medics, we can provide medications. We can provide pharmacologic restraints with things like ketamine and Versed. But again, you still got to get close enough to that patient when they're acting out violently to be able to inject that medication in them. When you have anyone who's violent, you make sure the hospital's aware, make sure security's at the door waiting for you. When you have someone in restraints, you need to make sure you check those motor neurosensories in the arms and legs every 5 minutes. So some of the types of emergencies that we're dealing with: acute psychosis. So psychosis is a state of delusion in which the person is out of touch with reality. These are the people who are hallucinating. They think the government's out to get them. They can usually answer questions about who they are, where they're at, their age, and everything else. But everything else is altered. And sometimes they don't even know where they're at. But a lot of times, from my experience, these people can answer questions, but they think they're Jesus. Uh, they think the government is reading their brain waves, uh, things of that nature. Schizophrenia is a common disease in which you see psychosis. Some of the signs and symptoms right here: delusions, hallucinations, a lack of interest and pleasure, erratic speech. You'll also see some sporadic or body language that's really like disjointed. Again, established safety. You don't want to argue with the patient about, no, you do not see that person there, they are not there. You just sort of go with it. You don't want to uh, make it worse by less feeding into it, but you don't want to argue with them. You just document. Now, you can ask them, though, is if it's, they're hallucinating with voices, ask them what the voices are telling them. Because if it's telling them to kill themselves or to kill other people, that's very relevant. Uh, because sometimes they get these command hallucinations, which cause them to uh, act out aggressively, violently towards themselves or others. Again, be calm, be straightforward, do not argue. Take these patients to the most appropriate hospital. Again, if you do not feel safe in the back, or this person is acting out aggressively, or you want to make sure that you have help in the back. You can't take family members in the back per our company's guidelines, but they might be able to help calm a patient down on scene, get that person to voluntarily go with you in the ambulance. But again, you might have a long ambulance ride, and after 20 minutes in the back, that person starts to have misgivings about going to the hospital, and might start talking about how they don't trust their family. So again, sometimes long transports can make these patients, can be very difficult for these patients. Excited delirium. This is a condition usually related to drug use. The person becomes extremely agitated and aggressive. They hallucinate, they're disoriented, they have delusional thoughts. Heart rate goes through the roof, breathing goes through the roof. Very combative, very strong. Signs and symptoms here: hyperactive, irrational behaviors, vivid hallucinations. So hypertension, tachycardia, diaphoresis, dilated pupils. These are the people, when the police have to fight them, they're already beaten, having a heart rate of 180, 200, and then they have to be restrained physically by law enforcement, and they end up having a massive heart attack or a stroke due to their cardiovascular issues related to excited delirium. Even when they're handcuffed and restrained, they are fighting these restraints with all sorts of strength. With us, again, luckily, as medics, not as EMTs, we are able to sedate these people in many cases once we can safely get to the patient. And sometimes these patients we might not be able to safely get to them until they've basically put up a huge fight and they have 4 people on top of them. And we approach them with a loaded syringe and we grab some sort of butt cheek muscle and just shoot up that medicine into that muscle and hope that it takes effect pretty quickly. So be calm, be supportive, be empathetic. We cannot always de-escalate patients, whether or not they're having a psychotic episode or excited delirium, but we can always make situations worse. So sometimes our calm, supportive methods do nothing, but I can almost guarantee you raising your voice and becoming aggressive in your approach will always make things worse. All right. Limit your physical contact. It can cause increased agitation, especially if they're hallucinating. Don't ever leave these patients unattended, and definitely don't be with this patient by yourself. Okay. So again, things that you're looking at when you're assessing this patient: their ability to communicate. How are they speaking to you? How are their eyes? Are their eyes tracking? Are their eyes going all over the place? Or can they sit still? They look like they've been up for the last 3 days. See what type of drugs might be found in the house. Are they on crystal meth? Are they on some other mind-altering drug? Call for ALS for these patients. Definitely, we want the chemical restraint much more safe for you and for your patient to chemically restrain someone than to have to physically restrain someone. But in a lot of cases, you will have to physically restrain someone in order for us to inject them with the medication needed to sedate them. And that's a big issue that we've gone backward and forth, is if we see someone who is not with excited delirium, but they are angry and you can see that they have the potential to become explosive. In my opinion, I think we should be able to provide a slow dose of Versed to just relax them for the transport. The first thing that these patients get who aren't acting out physically or aggressively, but are just sort of displaying some aggressive type behaviors, the first thing the hospital gives them is some sort of sedative, and we carry sedatives. So I wish, and it's a medical control issue, that we could provide a lower dose of Versed for our patients that are agitated but actually haven't become significantly aggressive yet, just to keep us safe in the back of the ambulance. So we'll see in the next few years if they do start letting us do that. We talk about restraints. Again, restraint should be the last option. Usually the police, if we have to restrain a patient, the police should be there. That's a safety issue. We don't go to scenes where patients are acting out violently until the police are there. And because then we become the patients, and it's not okay. We're not going to go run in there with the 4-man engine crew and the 2 crews on the ambulance and take on this person who is swinging a bat at everybody due to hallucinations. Unfortunately, it falls onto the police. All right, so we need to be properly restrained in restraints. You need to have a plan. Everyone needs to have BSI scene safety. If you're going to restrain someone, they're going to be biting, they're going to be spitting, they're going to be doing all sorts of nastiness to you. So make sure everyone has proper PPE. I would look at masks, goggles, gloves at a minimum. Make sure everyone has a plan. You're taking left arm, you're taking right arm, you're taking left leg, you're taking right leg, you're holding onto the body. And you, medic, you stand out of the way and get your medication ready. And once we all do the work, you come in and shoot that drug in the butt cheek and be the hero, because that's what paramedics do. All right, so again, protect yourself and others from bodily harms. If you look at this patient, for example, in this picture, that patient needs to have, looks like they actually do have some soft restraints. You need to follow your agency's protocols on how to restrain someone and how to position them. The big thing, we never, ever, 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 never, ever, ever restrain someone face down. And we do not do what police do. We do not hobble tie. We don't secure someone's legs and put them face down and secure their legs or ankles to their wrist in this hog tie position. Never, ever, 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 ever. And again, if you can't safely restrain someone in your ambulance, then they don't get into your ambulance. Their emergency does not keep you from going home safely. Again, involve law enforcement, and if law enforcement's not available, then you tell your dispatch, then we're not going there. And it doesn't matter if that person, family calls 10 times over, they're tearing up the house, and if law enforcement's like, we don't have anyone at the moment, then guess what? You're not going there. Do not become a statistic and get your butt killed or injured because you thought you were going to be able to go and talk this person down because I worked in a group home or I took a counseling class. No, 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 no. All right, so here we talked about the process of restraining a patient. Again, it needs to be done quickly. A lot of times, they're going to see what's going on because they see the group of 4 or 5 people huddling together, so they know what's going on. You just figure out, as I said earlier, figure out who's doing what, have that team leader, use the minimum force necessary. We are not allowed to be punching people to calm them down or to take them down. It's a rapid all go in, we all grab what we need to grab, take them to the ground in an organized manner. They may be face down temporarily as you're restraining or as you get control of them, but once you get them onto that gurney, again, they need to be supine, face up, secure the extremities as needed, maybe put a spit mask on the patient if you have them. If you don't have a spit mask, you can always put a non-rebreather mask, pull the bag off the non-rebreather so you don't have to put them on oxygen, but you put some sort of mask on the patient. It can be a surgical mask, it could be a non-rebreather mask with the bag taken off so they can still breathe appropriately. I wouldn't use an N95 because remember, this person's already having a hard time breathing due to the amount of exertion they're doing, so you don't want to put an N95 that actually is pretty hard to breathe through. Patient sex, size, and strengths. I have had to restrain 8-year-old kids. 8-year-old kids have an amazing amount of strength. Do not underestimate someone based on their sex, size, and strengths. We had a police officer in Tucson who lost their eye because, quite frankly, I think they underestimated that this drunk girl, when she acted out, would become as violent as she did, and she was kicking and kicked this officer in his eye with the heel of her high-heeled shoe, and it took his eye out. So don't underestimate. Remember, you go home safely and you go home intact. That's your goal. Doesn't mean so there is a balance between making sure you use the appropriate level of force, but just remember, you go home safely. And anyone who's had to deal with a 4-year-old throwing a major temper tantrum, it's amazing how much strength is in a 4-year-old, let alone a 150-pound-year-old who's having a psychotic emergency related to drugs or some sort of mental health issue. Talk to the patient calmly, even though they're screaming that they're going to kill you and kill everyone and kill your mother and kill your father, kill your kids. Stay calm. It does help in many cases. Again, screaming at the patient definitely does not help. So talk to the patient. Hey, dude, hey, I need you to try to calm down. We're getting through this while everyone else is doing what they're doing. Just have that patient maybe focus on that team leader while everyone does what they need to do. All right. When you have that person in restraint, we're not giving them the evil eye. We get them to the hospital. We never leave a restrained person unattended. Again, 4-point restraints, arms and legs, monitor the patient closely, throw a pulse oximeter on their finger. You might be able to get a blood pressure cuff on them. If they're not spitting, put a nasal cannula on them. You can put a nasal cannula on them and then a surgical mask over their nose and mouth to give them some extra oxygen, especially if they're fighting and they're out of breath. Let's oxygenate them. Do anything that we can do to help calm down the heart rate, calm down that breathing rate. When we look at these potentially violent patients, again, they make up a very small percentage of the overall mental health population. And of all the mental health patients that we transport, they're a very small percentage of that population. But you just have to be aware of them because they do exist, and you do not want to be caught unprepared. So be alert for these signs of potential violence. All right, we're looking at history. Has this person had a history of being aggressive towards police, EMS, staff? How are they posturing? How are they sitting? Are they tense? Are they relaxed? Are they looking like they're ready to pounce at you? And just because someone's answering questions doesn't mean in the back of their head they're looking for a way to jump at you and break your neck. All right, look for objects that can be used for weapons. for you when you're in that house, make sure no one gets between you and the door. If that patient gets up and starts walking, you move. So there is no one between you and the door. If you're in the back of the ambulance, what's your exit strategy to get out of the back of that ambulance if this patient becomes violent? Even if you're on the freeway, have you and your partner discussed, hey, if this patient becomes violent, how are you going to pull over quickly and safely? So if this patient is going to suddenly pull off his seat belts and try to jump out of the back of the ambulance, which has happened throughout this country several times. But if they're in our restraints, they should not be able to do that. So you should be safe. But, again, you have to watch out for the thrashing, the violent behaviors, the increased heart rate, the increased breathing rates that go with that. Leaning over the patient and they try to pull their head up to bite you, things of that nature. And again, we're looking at also the type of speech the patient's using, the speech patterns that indicate emotional distress. The physical body language we've talked about, clenched fists, the glaring eyes, were they pacing at their house, they can't sit still, keeping people away, stay away from me, don't touch me. When you do touch them, they flinch back aggressively. Those are all things that, okay, this person, very potential that this person could act out aggressively. And a list of other potentially violent, other signs and symptoms of a potentially violent patient. Again, people on drugs are not rational. People with a history of fighting. The best predictor of future behaviors is a review of past behaviors. Just be aware of that. All right, so depression and suicide. All right, depression is the single most significant factor that contributes to suicide. Men commit suicide more often than women. Women attempt suicide more often. Men just happen to be more successful because men tend to use guns. Women tend to use drugs. We can fix the drug overdose a lot better than we can fix the 357 through the brain. Do not believe that people who talk about suicide will never commit it. People who commit suicide tend not to commit it in an isolated event. It's something they've talked about to others, sometimes in a joking manner, but not always. So when you look for that person who is extremely depressed, you're looking for those signs of depression, the inability to talk about the future, giving away belongings, and again, continuing to talk about suicide. These are your classic suicidal patient signs and symptoms or warning signs. But be aware that you have people who commit suicide who don't have any warning signs. They've kept everything inside, and boom, next thing you know, they've committed suicide. You have people who've talked about their emotions and feelings who, because they're talking about it and they're expressing, they're able to articulate what's going on, what they're doing, that you're like, hey, this person's good. They're, they know what's going on. They're coping with things through therapy and everything. That doesn't mean that person's never going to go home and commit suicide. Suicide, unfortunately, is not something we can prevent 100% of the time. But we don't want to be that person who did see something or hear something but didn't do anything. So just be, cognizant of that. All right, when you get a patient who is a history of suicidal ideations, is expressing suicidal thoughts, you want to check out their environments. Look at, do they have a means to commit suicide? We ask our patients, hey, you're thinking about suicide? Do you have a plan? And a lot of people like, oh, we don't want to ask them that because we don't want to give them ideas. Anyone who is suicidal, they have a plan. And being sad and wanting to die, that's different from being sad and wanting to die. And I know how I'm going to do it because I know when my mom goes to work, I know where she keeps the key to the gun lock, to the gun safe. And I'm just going to go grab the gun out of the gun safe and go into the desert and shoot my brains out when she's at work on Wednesday night. That's very different from, I hate my life. My life sucks. I just don't want to be here. I wish I was dead. And then, as mentioned before, a suicidal patient very well may be homicidal as well. PTSD and returning combat veterans, please do not always think that only vets can have post-traumatic stress disorder. There's a lot of children and adults, children especially, who have been exposed to so much trauma in their life due to bad parenting, violence within their community, that they have PTSD. You know, think about that kid who was getting beat every single night by their mom. They're going to have post-traumatic stress disorder. And then obviously we have our returning combat veterans who also have that PTSD. So what is it? It basically is the trauma, mental trauma that occurs after, it could be exposure to one event or multiple events of some sort of traumatic event. You know, it could be as simple as you saw someone get hit by a car on the way home, and you can't get out of your brain that visual of that person being hit by a car and getting thrown across the street. And now you're having nightmares about you seeing that. All right, so some symptoms of PTSD: helplessness, anxiety and fear. They want to avoid these things that can trigger these memories. You know, someone who saw that person get hit by a car, you know, they might have anxiety when they drive. They can't drive anymore. Veterans, the big loud noises, for example, might trigger the backfire of a car. They're very nervous. You know, when they enter a room, how they position themselves in a room, they get an anxiety attack when they're in a situation that triggers memories and flashbacks. And sometimes they can't control. It can just be dog barking. And for whatever reason, dogs barking that day triggered some sort of memory. I mean, we've all had these memories that we haven't thought about until something triggers it. And wow, that memory is clear as day. And it could be like, oh man, I forgot when I went on this date in the 8th grade with this one girl. God, I haven't thought about that date in so long. And boom, that memory of that date comes back for some reason. Same thing can happen with, unfortunately, traumatic issues where you could just be driving along and something that you don't even know triggers it, or just your brain pops it out as a thought that all of a sudden you're thinking about this traumatic issue that happened. So veterans, unfortunately, have an increased risk of suicide. It can happen due to the physical conditions related to combat that they now have to deal with, that they have that constant reminder of that traumatic event that happened while in while in combat. Many have brain issues due to traumatic brain injuries, multiple concussions and stuff, which can sometimes impair thought processes. When you're dealing with these, when you're caring for the combat veteran, again, unique level of understanding. Be careful how you phrase your questions. Understand many of these people have training on how to kill you, basically. So you want to be firm. You don't want to be aggressive. Respect their space. Respect their history, what they've been through. If they want to tell you their stories and that helps them, let them tell you their stories. You want to ask about their suicidal ideations and stuff and intentions, but sometimes just let them speak through the memories that they're having. But you don't want to probe too much because you don't want to trigger some memories that have come back. I had a D-Day veteran a few years ago. Not a lot of those guys around. This guy was 96 years old. And I remember taking him out of the VA, and the docs there were like, hey, take good care of this guy. There's not many of them around. He was in D-Day, June 6th. And as a history nerd, I was like, wow. And this guy he was still cognitively intact and everything. And, you know, you're just doing your small talk with this veteran in the back. And I started asking him, you know, like, you know, just your normal curiosity type questions. And I was asking him about that day, and he just you could see his eyes sort of roll back in his head, and he just started like almost crying about all those boys dying on that day. And I was like, okay, we're going to have to bring this back, because I just triggered this man by accident, just because of my own curiosity about, wow, this guy was at D-Day. So again, you can use some open-ended questions. If they want to talk about it, let them talk about it. If they don't want to talk about it, don't force the issue. All right, make sure we take care of our veterans, make sure we get them to the right facilities, make sure that there are support there for them. You respect with what they did, because sometimes they don't always feel like they have been given the respect they deserve, especially our vets that came out of Vietnam. They got treated like crap when they came back. Thank God we're doing a better job with our modern day vets, but they still have needs that need to be met. As with all mental health patients, safety is always your priority. Please, vets, just remember, if they know how to use weapons, they know how to do hand-to-hand combat. We don't want to have to tie these people down in physical restraints. And we never want to physically restrain anybody, but just remember with our vets, that can just really escalate the situation. Some of the legal issues with our mentally ill, and this is where the gray area of legality is it's there. You have the person who's conscious, awake, and oriented, and they don't want to go, but they're suicidal. Are we going to force them to go? I can say from my experience, I can almost always get that person to go to the hospital. But if you can't, it does become a law enforcement issue, and law enforcement may put them in protective custody and take them to the hospital against their will. All right. So just remember, the patient may resist your attempt to provide care. We never want to leave these patients alone. If they're like, hey, I'm going to go with you guys, but hey, I need to go to my bedroom and get my stuff. Someone needs to go with them to their bedroom to get their stuff. And again, with most of these mental health patients, we're going to have law enforcement there because of the safety issues. Consent becomes an issue. Again, implied consent is, we're going to assume a patient of who's thinking rationally would want to be treated. So if you have that person who's hallucinating, has this altered mental status, is not thinking properly, they can't tell you, no, I don't want to go to the hospital. The big issue is, how do you get that person to voluntarily go without fighting them, since they're being resistant based on their mental health issues, but you can't leave them there knowing that they're not thinking properly. All right, so these consent matters are not always clear cut in these psychiatric issues. So we can always use law enforcement, and we also can always call our hospital and get guidance from our medical control. And from my experience, our medical control will always say, nope, you have to bring them in any way you can. And that involves escalating situations sometimes. The limited legal authority, we have limited legal authority to require a patient to go based on their signs and symptoms if they are exhibiting a mental status that is life-threatening, or not necessarily life-threatening, but is not normal. So that person wandering down the street yelling at cars and talking about the Martians coming to take them away, are they going to die from that right now? No, but we can't leave that person, as I said, so we can't let them refuse. In a court of law, you're going to be protected. If that person tries to sue you for kidnapping them, you will be protected in a court of law. You just need to document why you restrained that person, why you forced them into the hospital. They get to the hospital and they're like, I don't want to be here. I don't know why I'm here. You have the documentation to prove, hey, I couldn't leave this person there. They're yelling at cars and they're talking about Martians coming down to take over the world. The worst case would be if the next day Martians did come down and take over the world, and then you're sort of like, crap, I probably should have listened to them. But as of right now, you're good. All right, now you have your review questions. Again, please go over these review questions. If you have any, when we meet in class, we'll go over any questions or concerns on this chapter, and we'll see you when we see you.